Today's PowerPoint will be a review of the anatomy of the knee and some common clinical conditions that you will see in therapy. Please review your anatomy of the bones of the lower extremity and be able to palpate areas as well as know what muscles attach to these bony landmarks that are listed. The tibiofemoral or knee joint is the largest joint in the body and actually has two articulations within the same joint capsule, that of the tibiofemoral joint and the patellofemoral joint. The knee does have 2 degrees of freedom or 2 planes of motion, and that would be flexion and extension, which we have voluntarily and which we will measure. And then there is rotation that also occurs at the knee. We will not measure this in goniometry. I do want you to view these 2 videos. They are both on this rotation that occurs at the knee, and it's what we call the lock-home mechanism. The first video is going to be showing the motion on a skeleton, and then the second video is going to be how you can show that this rotation has occurred, and we will do this little exercise in lab as well. I have placed these videos under the module for lower extremity. Also in the knee joint, you have a medial and lateral meniscus, which sits right on the tibial plateaus, which deepen the joint surface and also provide some cushion. We will talk later in the PowerPoint about possible meniscal injuries that occur from wear and tear or from sudden motions or torque that is placed on them. We have 4 ligaments in our knees that provide stability to the knee joint. We have the medial and lateral collateral ligaments, which will provide protection in the frontal plane. So the medial collateral ligament will prevent excessive valgus forces at the knee, whereas the lateral collateral will prevent excessive varus forces at the knee. If you are unsure what the varus and valgus force is, please ask that question when we meet in lab. The anterior and posterior cruciate ligaments cross within the joint. So they have an origin on the femur, and then they will also have an attachment on the tibia. They are named for their attachment on the tibia. So the anterior cruciate ligament will begin on the posterior femur and will attach then on the anterior tibia. Please watch the video that I have posted under this module. This will show a skeleton with the ligaments attached and seeing the forces that are placed on each of these ligaments as the knee moves through flexion and extension. There are 14 bursae located in the knee joint. You see 3 listed on this slide, and they are named by their location. So suprapatella would be above the patella. And so just like in other joints in the body, the bursa can become inflamed with irritation either through weight bearing or through malalignment, which then causes more force on the bursa, or maybe from a tendon or a ligament that's rubbing or irritating. This slide reviews the muscles that flex and extend the knee. So please review them, and we will be doing manual muscle testing in lab. Take a look at this knee of a cadaver and see both the medial and lateral meniscus as well as the anterior cruciate ligament. During anatomy in the spring, we were able to see the knee and see the inside the knee joint. Look how smooth the surface is of the femur. Doesn't look like any arthritis in this knee. On this slide, the femur has been removed, and we have a superior view looking down at the tibial portion of the knee joint. Please review and see that you can see the tibial plateau, and then you can see the medial and lateral meniscus. You can see the distal attachment for the medial and lateral collateral ligaments. You can see the tibial tuberosity and also the anterior and posterior attachment, cruciate ligament attachments on the tibia. Here's a posterior view of a cadaver knee. You do see that there is some fatty tissue present. You can see the condyles, the femoral condyles being revealed, as well as the anterior and posterior cruciate ligament. Posterior knee is often a place where edema can collect as well. The Q angle is the quadriceps angle, or the pull of the muscle, what that pull has on the patella. It is a clinical assessment that can be used to look at patella tracking, or looking at the potential for risk of subluxation or patellofemoral pain with flexion and extension of the knee. So how we will measure, and we will practice this in lab, is you will look at the angle of the quadriceps muscle from the ASIS to the center of the patella, and then looking at the patellar tendon from the center of the patella to the tibial tuberosity, and then we'll look at that angle, that those two lines when they intersect. Normal Q angles for male is 14 degrees, and for females is 17 degrees. We will now look at some common clinical conditions of the knee. A total knee replacement or total knee arthroplasty is done often for patients who have severe arthritis, whether it's osteoarthritis or rheumatoid, and they have lots of pain and weight-bearing dysfunctions. Total knee replacements can tend to be even more painful than a total hip, and they do have a higher risk of infection due to the where the incision is, and it's usually uncovered. Patients will be seen in acute phase, and they will have staples, and some of them even have it where the incision is glued together. They may even have a bulky bandage initially, and some may have a knee immobilizer when you first start if they've had a femoral nerve block. That could be if they haven't regained the full sensation, so the knee immobilizer would prevent knee buckling. And then also, dependent on the surgeon, you may have orders for a CPM, a continuous passive motion machine. It is really dependent upon the surgeon. And those machines, I believe you saw them in the spring semester, is where you would have the leg sitting on top of the CPM, and then it would take the knee through a certain amount of flexion and extension that would be set by you as the PT, by the PT and the PTA. So in the acute phase, meaning when they're in the hospital, mobility is a focus. We are trying to get them up sometimes on their day of surgery, depending on when the surgery has occurred. The PT may do the eval on that day. And we will begin with transfers mobility. Usually these patients are weight beared as tolerated, and you will be using a walker, and they will be able to put some weight through it. You will be teaching them some active range of motion exercises to prevent DVTs, as they have a little bit less mobility than their normal. You can do some cryotherapy modalities to help to decrease with pain and edema. You also want to look at some muscle stretching. Trying to get the full knee extension is often a challenge. So we definitely don't want to have these patients propped up in the bed with a pillow under their knee. Even though they may feel like that is comfortable, that'll help to increase the tightness and have a much more challenging time getting a full knee extension, which we need that full knee extension to have a normalized gait, and so we can get that nice heel strike with our knee extended. These patients will continue in outpatient usually. Now, if there are some complications, you may see this patient go to a skilled nursing facility or inpatient rehab, but these would be patients that would have more comorbidities and have a more challenging progression. Otherwise, patients will usually go home from the hospital and then begin either with home health or outpatient physical therapy. This slide shows you the before and after After a total knee replacement or total knee arthroplasty, you can see the metal components of the prosthesis that cover both the femoral condyles and the tibial plateau as well. Here you can see the prosthesis on radiograph, and you can see that there are two different styles of prosthesis, and it would be dependent on the bone quality of the patient and also surgeon preference. Please review the video on this slide, which has been posted under this module. It is a video of a surgical procedure of a total knee replacement. You'll be able to see how they maintain or prevent infection, as well as how they align the prosthesis and determine what is the proper fit for this patient. Patellofemoral dysfunction is a pain in the anterior portion of the knee that is a result of poor patella tracking. This can come from an imbalance of muscles. So it's going to be important as we go through our assessment with the patient, and you can see there are several special tests listed there. OBERS, which would look at the IT band, looking at other muscle lengths of the quad and the hamstrings, and then looking at the Q angle, and looking to see, is our patient out of alignment? Are we putting that patella or forcing it to track not in the femoral groove, and so it's giving a lot of pain with any flexion and extension? So you see that for clinical management, we will use modalities to help decrease any inflammation and pain. We can also use different bracing or look at patellar taping, whether it's McConnell taping or kinesio taping, to help provide or to help align that patella so that when we ask our knee to flex and extend, it will be causing that pain and irritation. We'll also have to look to see which muscle is weak. Often the vastus medialis or the VMO, the quadriceps, can be weak, and then we'll have the vastus lateralis, which will be stronger and then pulling patella laterally. And so a lot of times we may have to target the vastus medialis, or you can see that there are other muscles that we may need to look at too to see if the weakness or an imbalance is the issue. Whenever we do exercises with this patient, we are going to make sure that we are doing it in a pain-free range, because if the symptoms continue, then the irritation is only going to get worse. This slide is a reminder for you to listen to your patient and to ask them specifically, where are you feeling pain? Can you point to it? And when they are able to identify a specific area, it can give you an idea to the structure which may be involved. You know, whether it is above the knee, then you might be thinking quadriceps tendon, or if it's down at the tibia tuberosity, you're thinking of the patella tendon and its insertion. If you're thinking that it's medial lateral, you're thinking those ligaments or maybe even the meniscus. And so it just kind of gives you an idea of, when you're asking the patient, it can help you decide what other special tests you may need to do, or what strengthening and stretching exercises are required. The medial and lateral meniscus of the knee are there to help broaden the joint surface as well as to absorb shock and distribute some weight-bearing forces. They also help to increase the stability of the knee. So if an injury occurs, which usually occurs when the foot is planted and the knee is locked and there is some type of rotation moment, then they are they have a very poor blood supply, or they're avascular, so they really heal slowly, if at all. So once the menisci have degenerated, it's going to cause degeneration within the joint. So some signs and symptoms that our patient may have is they may feel like their knee will lock in flexion and not able to fully extend their knee. They may have some pain initially and some swelling. And then you see we have McMurray's and Apley's special tests that we can do to look to see if it's a meniscal injury. Now, clinical management, if it's non-surgical, we're going to look at doing some open chain exercises and any modalities for pain or swelling management. Now, surgery, it can be where they go in and do a meniscectomy, where they remove the meniscus, or they can go in and repair it or do a partial removal. So then we're going to have to, decide or follow what the surgeon's saying, depending on if it's fully removed or repaired. If it's removed, their progression will go more quickly, that they will be partial weight bearing for a shorter period of time, and maybe up to 2 weeks at the most, and look at range of motion and isometric exercises. If it is a repair, it's going to be much more protective. They're going to be restricted in their weight bearing for about 6 weeks, and not even just in their weight bearing, but in the range of motion that they are allowed. Usually they are capped with an extension and allowed to only flex up to 90 degrees, and so we'll have to follow that progression. Oftentimes, when the meniscus is injured, the patient can have either the ACL or MCL injury with the medial meniscus, and they are often injured together. So if there is more structured injured at the same time, obviously the recovery will take longer. Osteochondritis dissecans, which we saw earlier in the semester in the elbow, can also occur in the knee. And it occurs when part of the articular cartilage or subchondral bone, due to a lack of blood supply, maybe there was some trauma and then lack of blood supply, that it actually breaks loose. The loose bodies can be floating within the joint and can cause pain and restrictions in range of motion. Non-surgical approach is going to be protected weight bearing and immobilization of the joint. But if they're continuing to have pain and have that free floating piece of subchondral bone, then it's going to have to be a surgical option, either where, depending on the severity, if they can actually just remove the floating bone piece, or they may need to go in and stabilize with pins and screws, or if it's severe enough, they may need to actually have a total joint replacement. Sprains of the knee ligaments can occur depending on the force, the direction of the force, whether it injures the anterior cruciate ligament, the posterior, or the medial and lateral collateral ligaments. These ligaments provide the stability of the knee joint, so if there is an injury or a sprain, it could have joint laxity. And if we continue to have joint laxity, it could actually lead to some more arthritic conditions. So in therapy, we're definitely going to want to work on strengthening of the muscles that cross the joint to help to provide the stability. As a review discussed earlier too, we can look at what each of these ligaments, what direction or what do they prevent. So the ACL is going to limit anterior translation of the tibia, whereas the posterior cruciate ligament is going to limit posterior translation of the tibia. The medial collateral ligament prevents the valgus stress at the knee, and the lateral collateral limits the varus stress at the knee. Oftentimes, you will find that depending on the force, usually it's a valgus force on either a valgus or rotational force on a planted foot will lead to a ACL, MCL, and medial meniscal injury. Depending on the severity, we have 3 different grades of sprains. As a reminder, we talked earlier, a grade 1 is where there's a stretching of the ligament. Usually there's minimal pain or swelling. We probably won't even necessarily see any patients when they've had a grade 1 sprain. A grade 2 is where there's a partial loss in the integrity of the ligament. The ligament remains intact, but there are some fibers within the ligament that have been torn. And then the grade 3 is where there's a complete tear or disruption of the ligament. In therapy, in addition to wanting to improve the stability through muscle strengthening, we'll be looking at the inflammation and pain, and so doing modalities to decrease those. Also looking at the patient's gait and see if they have an instability in their gait as well. This slide again shows you the anatomy of the unhappy triad, the anterior cruciate ligament, the medial collateral ligament, and the medial meniscus. Again, having that fixed foot with a valgus or rotational force will often cause injury to all three of these structures. This slide further details the clinical management for non-surgical treatment of the medial collateral and the anterior cruciate ligaments. What's true for both is that you are going to want to control for edema and inflammation and decrease pain, and then to also protect the joint since it will have increased laxity. And not just protecting for laxity, we want to make sure, depending too on what grade sprain this is that we don't want to further stress that ligament. So for the medial collateral, we are not going to want to apply a valgus stress in the frontal plane of the knee because that may cause further damage. The anterior cruciate, we are not going to want to have that terminal extension where the tibia is translating anteriorly on the femur. So we'll definitely want to protect those areas while it's continuing to heal. And then we'll progress our patients through and do some isometric exercises, and then progress to closed chain and open chain where it would put the stress on the ligament as it is healing. You can view the video showing how an anterior cruciate ligament reconstruction is performed through arthroscopic surgery. Surgery can be an intervention for either a grade 2 or grade 3 sprain. And when they do surgery, they can either use an autograft or an allograft. Autograft is where they are going to take a portion of another tendon, of that patient's own tendon. A lot of times it can be the part of the patella tendon or part of the hamstrings. And then an allograft actually comes from a cadaver. We are going to be looking at when a patient has an ACL reconstruction, that surgeon is going to have a protocol that you are expected and required to follow. So it'll outline when you could do certain exercises, when weight bearing is allowed, also looking at when the patient can come out of their range of motion brace, because they will be placed in a brace that's going to limit their range of motion. Again, the anterior translation of the tibia is what the anterior cruciate ligament prevents. So we don't want to do that motion, which will put stress on a healing ligament. So no full terminal extension. Usually they might be able to do some active range of exercises in a open chain, but in the beginning parts of flexion. Usually about 45 degrees of flexion to 0 degrees is avoided until there's definitely enough quad strength because of that tension. Sometimes patients may even start to do closed chains exercises before they do terminal knee extension. You also could use Easton with these patients to help assist with the quad contraction. And then we are going to progress them though. So maybe they're going to start quite limited on crutches and limited weight bearing. And then we are going to progress them back to if they were an athlete so that they're back to running and jumping. So that why the rehab for these patients may vary depending on what level they must achieve to get back to their prior level of function. So in lab, we are going to practice goniometry of the knee, as well as manual muscle testing, and also looking at the special test to try to distinguish between ligamentous and meniscal injury.